Everyone to our third AADB teleseminar of 2018. I'm Richard Hetke. I serve as the Executive Director of AADB, and today's program is entitled Reducing the Risk of Deadly Dentistry. And if that doesn't catch your attention, I don't know what would. Today we hope to run for no more than 60 minutes. We have a hard stop at 1 o'clock. We will endeavor to speak for 30 to 40 minutes. Our presenters have a presentation of between 30 and 40 minutes, and that will allow 20 or 25 minutes for questions and answers. Now, all of the audience lines have been muted and are in listen-only mode, and that's just to preserve the integrity of the call and avoid disruptions. If anyone in the audience would like to send a question to the speakers to be answered during the program, they can email them. Email the questions to AADB staff member Donna Adler. Donna's email address, and I think it was provided in a few of the promotional flyers, but I'll give it to you again. It is dadler@dentalboards.org. That's DADLER @dentalboards, all one word with an S at the end, .org. When Donna receives any questions, she will immediately send them to the two speakers. They'll try to answer them in the Q&A session. If we don't have enough time, all the people who will send in questions will receive either a call or an email from one or both of the speakers. Just want to make sure that everyone knows our speakers are working on products and services, have a company that's endeavoring to design products and services that speak to the issue, that address the issue of emergency preparedness. Like so many consultants and vendors who speak at our other continuing education courses, one of the reasons they do that is to talk a little bit about the products and services they offer. But this is not a commercial. First and foremost, their objective is to talk about the magnitude of this issue and some of the things that dental boards and other regulators can do to reduce the risk of deadly dentistry. Let me introduce the two speakers right now before we get started. Dr. John Robertson is the chairman and co-founder of the Accreditation Association of Dental Offices, or AFDO. Dr. Robertson has more than 20 years of experience as a board-certified oral and maxillofacial surgeon. John's widely published in the fields of oral surgery and patient safety. He's the founder of Emergency Products Institute, and John holds numerous fellowships and memberships in dental organizations, too many to name today. We'd go over overtime. Stephen Harden, the other speaker. Stephen's a managing director and co-founder of the Accreditation Association of Dental Offices. Mr. Harden is also the chairman and CEO of LifeWings Partners, a team of physicians, astronauts, nurses, and pilots that have helped over 200 healthcare organizations implement best practices for patient safety. Steve has been involved in safety training for more than 20 years, focusing on the subject of emergency preparedness. And in his spare time, he's a pilot for Federal Express, so he probably helped you get that Christmas present to Aunt Edna there to her house on time 2 or 3 years ago. So, Steve, I think you're up first. Take it away.
All right. Thank you, Dick. I really appreciate the introduction. First, let me say that John and I are just very, very honored to have this time with you and members of AADB today. We're so appreciative of the work that all state boards do to maintain the standards and integrity of the profession, and most appreciative of what you do in terms of patient safety. I think you can understand from the intro that both John and I have a particular interest in patient safety, and we'll explain that to you as we go. And so we're really thankful for the time to advance the cause of patient safety in dentistry. We like to start out our presentations by just giving you an upfront idea of what this is all about. Honestly, this whole presentation is a deep dive into what we believe is an increasing patient safety risk caused by an increasing number of patient harm events and safety events related to dental office-based sedation and anesthesia. And beyond that, once we have a deep dive into that particular risk and why that risk is increasing, we want to explore with you a recommendation on how that particular risk might be mitigated. So, just as an overview, deep dive into the growing risk and what we might do together, what state dental boards might do to mitigate the risk. Our agenda for the time that we have together, we're going to spend a little bit more time introducing both John and myself. I think you have to really understand our interest in patient safety to understand where we're coming from to even talk about this particular risk. And after we do that, we'll take that deep dive into the risk. What's causing it? What are the confluence of factors that are happening within the dental profession that make this a growing and ever-present patient safety risk? And then we'll explore a recommendation on how we might address or mitigate that risk. So a little bit more about John and myself, our backgrounds and our interest in patient safety. As you know from the introduction, Dick's introduction, John's an oral surgeon, and beyond managing a very successful practice, he has for years been interested in patient safety. And John, just talk to us a little bit about some of the things you've done around patient safety and how you got interested in patient safety in dentistry.
Yes, Steve, thank you so very much, and I would also like to thank Dick for that introduction, and I also like to thank our audience for taking your time today to be present on such a very important topic. And as Steve said, I'd like to reiterate, thank you for what you do every day in dentistry. We love the field and the profession of dentistry. We must do everything we can to protect our profession as well too, and that also includes patient safety. I am a private practice oral and maxillofacial surgeon. I've been in private practice for over 21 years. I have dual board certifications, both oral and maxillofacial surgery as well as anesthesia. I have been uniquely involved as a co-founder of the Institute of Medical Emergency Preparedness as well as the Emergency Products Institute. I am an expert in medical and sedation emergency preparedness, having authored a book, have published over 100 articles, and I currently have 20 online courses in this area. And I have always been an advocate for patient safety because this is something I do every single day in my office. But I also lecture nationally and talk on this subject matter, and I can only stress to you how many people come up to me at every break, whether it be in between the lecture or at the end of the lecture, about issues that they're having in their office. What can I do to be better? What can I do to protect my patient? I feel inadequate when it comes to the possibility of facing a medical emergency. And a medical emergency is something that any of us can face any day, and we'll get further into that as well. Thank you, Steve.
All right. Thank you, John. My interest in patient safety actually started out in a much more a personal way during the birth of my fifth child. I almost lost my child, and fortunately, because of my work in safety within commercial airlines and military flight squadrons, I recognized the warning signs during the birth process that something was amiss, and I also saw the breakdown in teamwork and communication, and I took it upon myself to intervene into the situation. And I called out the warning flags to both the obstetrician and the labor delivery nurse, explained to them what I was seeing. They were very appreciative. They agreed. We had a meeting about what we should do next. We ended up doing an emergency cesarean section. And when my son was born, during the C-section, they found out that his umbilical cord was wrapped around his neck twice. And it really dawned on me then that I knew a lot about safety from my work in commercial aviation and military flight squadrons that was applicable to the healthcare industry. And because of that particular incident, I got asked by that hospital and others to help them learn what aviation knew about increasing patient safety, and that started a 20-year journey of helping hospitals adopt best patient safety practices adapted from both the airlines and astronautics and from nuclear power. Because of our mutual interest in checklists and the impact on checklists and patient safety, John and I kind of bumped into one another, and as we began to survey the landscape in the dental profession, especially around patient safety events involving sedation and anesthesia, it was clear to us that there was something that we could bring to the equation, and that it was a growing problem that needed to be addressed. So really, that's our motivation, how we got into looking at this particular issue, and how we came to be on this phone call today. So let's dig into the patient safety risk. There's really the confluence of three big trends in the dental profession that are sort of coming together in a perfect storm to create an increasing patient safety risk due to dental office-based sedation or anesthesia. Now, the numbers, I'm going to throw some numbers out here with you, and these numbers are primarily from the state of Texas, and there's a reason for that, because this is an issue that's at the forefront in the state of Texas. I'm a native Texan. I grew up in Texas. I consider myself to be a Texan, and what happens in Texas is near and dear to my heart, but the availability of the data allows us to use this as an example, but you can extrapolate from the numbers that I'm going to give you in this discussion about these three trends to your own states, and I'm sure that these three trends are present in your state as well. The first big trend is that there is growth in dental office-based anesthesia. It's something that the marketplace wants. Just in the state of Texas alone, there are 7,500 sedation or anesthesia permit holders. And of those 7,500 dentists who have permits to do that, in a single year they provide anywhere from 2.5 to 5 million sedation or anesthetic procedures just in that state. Now, not every state has the population of Texas, but there are many large states that have very similar numbers, and no matter the size of your state, I'm sure the trend is similar in that the number of sedation or anesthetic procedures that are being provided is growing, right? So, you know, the first big trend is the growth in sedation and anesthesia services. The second big trend, if we look at the data and root cause analyses of when there are adverse events or patient harming events in sedation or anesthetic procedures, is evidence of poor response to emergencies. Right? So obviously most of the time it goes very well. The times that it does not go well, where the patient has some sort of adverse reaction to the medications, handling of those emergencies is not being done well. Typically those issues revolve around compromised ventilation, but mostly around poor emergency management. The dental professionals are just not prepared or properly equipped or have their operatory set up correctly to respond to that emergency. So just in one state alone, in the state of Texas, over the last few years, there's been 5 deaths and 1 severe permanent brain injury. Nationwide, since 2010, so these numbers actually came out in 2017, there's been 85 deaths. But that's really an incomplete picture because no one really knows, because of reporting problems, how many deaths there have been across the country. So we see 2 of the trends here is growth in the number of sedation or anesthetic procedures, but also because of that growth, there is an increase in the number of opportunities for those procedures to go awry and a poor response to those emergencies. So that brings in the third trend, and that is looming legislative imperatives, right? So state legislatures are taking notice. I'm sure many of you and your state boards have had discussions with your state regulatory authorities, your legislatures, around what are we going to do about this issue, right? And one of the reasons that it has come to the attention of state legislature, and there are looming legislative imperatives, is because of the public outcry. We'll talk a little bit more about that here in a second. So you put those three trends together, there's a growing problem, growing number of instances where response to emergencies have not been handled well, and growing attention from regulatory authorities. So it clearly is a problem that needs to be addressed. So digging a little bit deeper, I know we say that there is growth in the number of sedation and anesthetic procedures that are provided. Dental Economics ran an article not too long ago that said that 40% of general dentists in the United States are offering some form of sedation, and at least in the adult dental practices. For those board-certified pediatric dentists, it's estimated that 70% of them provide some form of sedation. Now, what's interesting about that is those numbers are growing, and dentists who've been providing sedation or anesthetic procedures for a number of years say that they are seeing a significant uptick in the number of patients that have heart conditions, diabetes, liver and kidney ailments, and other challenging medical conditions requiring a deeper understanding of the safety precautions. So as this grows in the marketplace and a wider and broader spectrum of patients present themselves for dental procedures who are either asking for or are good candidates for sedation or anesthesia, there's going to be more opportunity for a response to emergency situations. One newspaper who in the state of Texas that has delved into this area, just looking at nationwide data, has made the claim that a dental patient dies nearly every other day in the United States. And again, that data is incomplete, but it does show you the depth of the issue. One of the organizations that's watching the situation very closely is the American Society of Anesthesiology, and they recently published an article in a journal saying that adverse events in dental office-based settings associated with sedation or anesthesia care have continued to occur with an unacceptable frequency. So it is a problem that is increasing, and typically as we look at the root cause analyses, at least what's clear to John and I is that the major issue in the root cause analysis seems to be poor response to the emergency situation, right? And so if that's where the primary causal factor is, then that's the one that ought to be addressed. Now, if you look at these numbers, and I often compare anything in patient safety related to and relate that to airline safety. If you look at these numbers just overall in terms of absolute, the dental profession, thanks to the work that you do and thanks to the work that dentists do, is quite safe. In terms of absolute numbers, this is doesn't appear to be statistically a really significant problem. The issue is in public perception, right? So one of the ways we measure safety in the airline industry is through the use of a manufacturing measurement called Six Sigma. So Six Sigma is a way of looking at the number of defects in 1 million opportunities to do something. And the gold standard, Six Sigma, or 6 standard deviations, means that there are less than 3.2 defects in 1 million opportunities to do something. And that's typically the gold standard in any sort of process operation or safety operation or manufacturing operation. Can you have less than 3.2 defects in 1 million opportunities of doing something? Well, as you can see from the data that we looked at in the state of Texas, and if we apply that across the whole country, there are millions upon millions of sedation or anesthetic procedures that are being provided, and they're being provided quite safely. and although I haven't personally run the numbers, I mean, just on face value, it seems as though that the standard of Six Sigma has been obtained. Well, that actually works against you in public perception, because when there is an adverse event or a patient safety event and an anesthetic procedure, there's such a sense of a betrayal of trust or a violation of trust, because people expect high levels of safety in those sorts of procedures in the dental chair. And when there are not, that sense of betrayal leads to headlines in the public's perception. Well, I'm just going to read you a few of the headlines that have come out in the last couple of years across the country around this, and it really, I think, is driven by the sense of betrayal of trust. So from the Dallas Morning News, the headline was "Junior Story, Drugged to Death in a Dallas Dental Chair." On the Today Show on a national network, ran a series called "Danger at the Dentist Office." There are new concerns around sedating for oral surgery. From a major newspaper in California, death blamed on sedatives in dentist chair. From another TV station in California, child dies at dentist office. And from a TV station in Texas, child dental death lawsuit in Austin, Texas. So these are just a smattering of the things that are available on a Google search. It will turn up a lot of stories like this. And again, it's really the level of safety that is present is already working against the public perception, because when it does happen, there's such a strong betrayal of trust. So there is a risk. What to do about it? And so what John and I would recommend, and what we have personally worked on, is that, and I know this from my own work in aviation and my work in hospitals, especially in the operating rooms, is that you never really know you're ready until you are tested in a safe or a simulated environment. And this typically means that some sort of inspection, comprehensive, structured, systemized inspection is performed. So to perform an inspection, and again, John knows this from his patient safety work, and I know it from my work in both the airline, the military, and in hospitals, is you have to have one source of truth, right? So you've got to get all the experts together and produce an inspection document that comes from one, that produces one source of truth. So what are all the nationally accepted standards, and can you compile them into one source of truth for an inspection around safely providing sedation and anesthesia services in the dental office, but also be able to respond appropriately to medical emergencies that are sure to arise, right? So that one source of truth should look at things, as you know, like credentialing, licensing, permitting, do you have the proper training and education? But more importantly, and this is especially true if the major issue and the root cause is poor response to medical emergencies, that one source of truth should also look at whether your facility is correctly set up to handle both normal and normal sedation and anesthesia services, but also those situations where it turns into an abnormal situation, right? Are you schooled in patient selection and the confounding factors that different patients present? And most importantly, do you have the proper safety precautions, and do you know and can you use the resuscitative and emergency protocols? Because those emergencies are going to happen. The data tells us that that's where the issue is around poor response to emergencies. So where should that one source of truth come from? Clearly you're going to need to talk to MDAs, so doctors of anesthesiology, and especially those who specialize in anesthesiology for dental patients. You'd also want to talk to dentists that specialize in medical emergency preparedness and the use of conscious sedation and anesthetic procedures and in patient monitoring. You'd also want to tap into the resources of dentists who are in an academic environment and are teaching other dentists around sedation training and emergency management training, and you'd want to work with risk managers. So that one source of truth you really have to go out and find a wide variety of experts across the spectrum of sedation and anesthetic procedures and get them to agree on this is the compilation of the accepted standards. So once you've got that one source of truth, how would you use it to provide an inspection? So in other words, what would an inspection look like? Well, you've got to go to the dentist's office, to where they practice, and you've got to apply that one source of truth. Well, it wouldn't be fair to the dentist to apply that one source of truth if you hadn't prepared them with that one source of truth, right? So before the inspection, the dentist is going to have a preparation checklist that goes through the compilation of all those national standards so that they know what they're being inspected against, right? So a successful inspection, systematic, comprehensive inspection process would have to contain a preparation checklist so that dentists could prepare against that compilation of the national standards. And because when you look at the root cause analysis and you know that poor response to emergencies is the primary causal factor in the root cause analyses, then the other thing dentists would have to have as part of their inspection process or to prepare for their inspection process would be in a mock emergency drills guide. What are the likely emergencies that statistically you're most likely to face if you're providing sedation or anesthetic procedures, right? And this is very similar to what we do in the airline business. We know from decades of data which pieces of equipment are likely to fail on an airliner and which sorts of weather phenomenon are most likely to cause issues on a flight. And because we know that from the data and we know that from accident root cause analysis, we know we've put together a comprehensive syllabus of emergency drills to practice both in the simulator and in the airplane, right? And so that same concept applies to the dentist. They need to have a comprehensive set of mock emergency drill guides to practice against if they're going to be adequately prepared and adequately perform when an emergency arises. All right, so once they have the preparation checklist, once they have their mock emergency drills guide and have time to prepare, then conduct the inspection against the compilation of the national standards. Another thing that systematic, comprehensive inspections should include would be the awarding of continuing education units, because it takes time and training to ensure that you are perfectly prepared and ready for the inevitable medical emergencies related to sedation and anesthetic procedures. So any inspection process should also include continuing education credits. Now, not every dentist obviously provides the same kind of anesthesia or sedation, right? So some people do local, some dentists just use nitrous oxide. Pediatric dentists are obviously doing pediatric sedation. So you can have anything from general anesthesia, minimal, moderate, or deep. So a huge part of the inspection process is to understand what sort of sedation and or anesthetic procedures the dentist is providing and customize the inspection to what they're doing, right? So you don't want to impose unnecessary obligations or standards on them if they're not doing a particular type of anesthesia. So the two things we know about inspections is, one, they should be comprehensive, and two, they should be customized to what the dentist is actually doing. the inspection, obviously, then, if it's against a compilation of the national standards, obviously has to be thorough. So you're going to look at things like qualifications and training and documentation and those sorts of things. What we found in the testing we've done around inspection so far is that it's really important to look at emergency medications to make sure they're in date, that there are emergency protocols, they're present, they're written, the office staff is trained to use them, they know how to find the emergency equipment and how to operate the emergency equipment, and that it's in good condition, and that they're actually doing monthly or periodic drills, right? So their preparation is never going to be, or their level of performance is never going to be any better than their level of presentation. So inspections should be comprehensive of the national standards. The dentist should be prepared for them through the use of a preparation checklist and mock emergency drills. They should be thorough and unbiased. And that's exactly what I've experienced as a professional aviator. I've been flying in the airline business now almost 33 years, so I get 3 competency checks a year where my basic certifications are checked, my license is checked, my medical is checked, and then my familiarity with emergency equipment and the ability to use the emergency equipment and the ability to respond in a mock drill are examined 3 times a year. So in a 33-year career, I've been examined well over 100 times. Now, I'm not necessarily recommending that for dentists, but, you get the point that you don't really know that you're prepared to respond to the emergency unless an outside entity looks at you in an unbiased way against national standards of performance. It won't surprise you that, if the major root cause of patient-harming events is poor response to emergency, then you really have to have, as a dentist, a comprehensive suite of written emergency protocols. John and I have studied this extensively. We believe there are at least 20 different scenarios that a dentist who is providing sedation or anesthesia should be familiar with and should train to. So any inspection program that's going to look at the ability to respond to emergencies should ensure that dentists have access to those 20 scenarios or mock emergency drills, and that they are on a periodic basis practicing against them. And if they're not going to be prepared, as well prepared as they need to be to reduce the patient safety risk if an emergency comes up. We have actually done some beta tests of these sorts of inspections. We just sought out some dentists that we've kind of explained the issue to them, what we were working on, and asked them if they would undergo a beta test of an inspection like this, just to make sure that we were on the right track in terms of how we were addressing this growing risk. And we've learned some interesting things. We did one just a couple of weeks ago where the dentist had just revised the way her office was set up, and so she had moved her operatories around. And although she and her staff thought they knew where everything was and all the emergency medications were and all the emergency equipment, it was very clear throughout the course of the inspection that they weren't as familiar with all of that as they thought they were. And I'm sort of putting words in her mouth, but it's very clear from her comments that she realized she wasn't as prepared for an emergency as she thought she was. We had the good fortune to do a beta test a couple of months ago with a dentist that had just gone through his inspection from the State Dental Board. And so he was able to show the inspector from the State Dental Board what this comprehensive, systematic inspection looked like as compared to what the state was doing, and even the state inspector said, yeah, this is way better than what we're doing. It's way more rigorous, and said that it was a better way to inspect. And then another dentist who told us that, look, it really dawned on me from the inspection that my performance in an emergency is never going to be any better than my team's level of preparation, and I just wasn't nearly as prepared as I thought I was. So we've been very encouraged by what we've learned from our beta tests, and we think we're on the right track to providing a risk mitigation strategy. So how does this apply to a state dental board? Whether you adopt this same sort of protocol for yourself, right? So put together what you believe to be the compilation of the national and state-specific standards and do these sorts of inspections as we've outlined them yourself, or whether you work with an outside entity to provide the inspections for you. We think it gives you a dramatic improvement in patient safety risk and addresses that growing patient safety risk. If you were to use an outside entity to do these sorts of inspections for you, that would allow you to concentrate more on patient complaints. The state boards that we've talked to typically say it's a resource constraint problem. We can either inspect people or we can respond to patient complaints, but it's difficult given the current budgetary climate to do both. So perhaps partnering with an outside entity would allow you to do both, address the patient safety risk, but also husband your resources to work on patient complaints. Right? So if you should use an outside entity to help you do these sorts of inspections, clearly there would be a cost to that. So the dentist would pay for these inspections, and perhaps there's some sort of revenue that could be captured from the inspections to help you with your budgets, non-dues revenue that may be able to help you with your state board budgets. So whether you decide to pursue using an outside entity to help you do this or you do it yourself, it's certainly something that needs to be done to address the growing patient safety risk. So we'll wrap it up by saying that we strongly believe that these sorts of inspections improve the safety of sedation and anesthesia practices in the U.S., and I think it helps dentists know for sure that they're providing the best and the safest dental care possible. All right, so that's our prepared remarks, and I think, Dick, now we'll open it up to questions.
Thanks so much, Steve. I've been watching my computer screen, and I know at least 2 or 3 questions have come through, which hopefully both of you, Steve and John, have. Would either one of you like to comment on a couple of the questions that I've seen come through? I'll turn it really back to you.
Yes, I'll be happy to. I'll address both questions. The first question that we received was in regards to where is the research source for the data of the 85 deaths from 2010 to 2017. That came strictly from the investigative report titled Deadly Dentistry. I would encourage all of you to Google that. It's one of the best, most investigative reports I've ever seen done, not just for that one state, but also nationwide. Deadly Dentistry. That is the title of that. The next question we received was in regards to your website for the AFDO. It states that you are the only organization that accredits dentists. We are. We are the only organization that accredits just dentists. We do not do any other healthcare practitioner or office. Yes, Joint Commission, AAAC, and Quad ASF does have some dental offices that have been accredited, but their major focus is hospital settings and ambulatory surgery center settings, or some of them are also getting into physician-based office settings as well too. But no organization is strictly just dentistry but AFDO. We are here for dentistry. We will support dentistry. We want to develop patient safety guidelines to work with you. The other question was, does AFTO offer something different besides just drill guides for emergency? Let me expand a little bit further on the mock emergency drill guide. It's an approximate 200-page document that our dentists will receive that is a plethora of information that they can use to create a medical emergency logbook that will show due diligence in the event of a bad outcome in your office from a medical or sedation emergency. Of all the dentists that we have been inspecting, as well as the many years of lecturing and talking to dentists, we are sorely lacking in the mock drill area. This is just one of the 6 links that you need in place so that you are prepared for medical emergencies. And our medical guide consists of a practice drill, the office emergency drill staff assignments, an emergency drug checklist, an AED monthly checklist, a quick reference checklist just for that specific emergency, a drug algorithm that you can use to make sure you have the right drugs for that specific emergency, and then just, once again, belts and suspenders, a preparation checklist. Now, besides just that, you'll also, one of the entities we're tied in with has an AED compliance management program called Trio Trek. It's by far the best AED compliance program you can have. You will also receive a critical office response to emergencies manual. We also call it CORE. It's a must-read for the entire dental team. And that concludes the 2 questions we've had so far.
All righty.
Steve, anything you want to add to that?
Well,
as far as JACO or AAAC?
No, I think I don't want anyone to get the impression that we think that the only answer to the potential patient safety risk of sedation or anesthetic procedures is a mock medical emergency guide, drills guide. That's an essential piece of it, but that's not the whole piece, right? So really what we've tried to describe in our presentation is the only way dentists will know they're really prepared for that inevitable emergency is to have an outside entity, whether it's the state dental board inspector or someone the state dental board has contracted with, to take an unbiased, comprehensive look at all of the national standards of performance around office setup, medications, emergency equipment, and then, of course, all the standard things that you would look at around certification, training, and education. But the key piece of it for us is an emergency will happen, right? And so at least once in everyone's career and possibly twice in everyone's career, there's going to be an emergency. And the only possible way that you will respond correctly is if you have practiced that particular emergency. You can't talk your way through it, right? It's all about doing. And the only way that you'll know you can respond correctly is if you have done mock emergency drills. But although a key piece, it's not the only piece of being prepared and mitigating that particular patient safety risk.
And I'd like to expand also on what Steve just said, because we are looking at many different factors when we come in to inspect an office. And by the way, our inspections are done virtually. We are all about high technology. It is quite impressive when you do undergo your inspection, our virtual inspection process. But we're looking at the personnel, both the dentist and the staff, looking at license and make sure everything is renewed properly. All of the various documentation in your office, whether it be the medical dental history forms, the pre-op and post-op forms, your treatment consent forms, BLS, ACLS, PALS, we're going to make sure everybody is up to date on that. Then we go into the office facility, followed next by your emergency drugs. Our inspectors are going to be looking at everything. Then we go into your emergency equipment after that, and then we end the session by looking at response to medical and sedation emergencies as well, too.
John and Steve, I think we had another question come in.
I just read it, and I'll address this as well, too, because many state boards have contacted us about this as well, too, because the delivery model of sedation in the dental setting is changing. Many private practitioners are starting to hire dental anesthesiologists, CRNAs, physician anesthesiologists. And there is that issue about mobile anesthesia or itinerant anesthesia. Our experience is that when we inspect an office, one of the 6 criteria I just said about the personnel, we find out about the dentist, the staff, all that are treating patients. Then we go a step further. Do you have an outside entity or sedation provider coming to your office? Because that person will also need to be available as well, too. We're not just going to inspect a general dentist office and say, okay, you have passed, then come later to find out that a sedation provider was coming in, say, on a Monday or a Tuesday. That person must also be inspected and be inspected to the level of anesthesia that he or she is providing within that general dentist office.
John, thank you very much.
Sure.
I don't see any other questions coming through. I want the audience to understand that if you have questions, if you're half as bad as I am, your best questions will occur about an hour from now or tonight or tomorrow. Once again, send the questions to the AADB office, to Donna Adler at the address that I gave you. Donna will get them to John and Steve, and one or both of them will contact you. So don't worry. Questions after the fact will be addressed as well. I think we're ready to wrap up the program. We try to stay true to our 1-hour hard stop. I've enjoyed it a lot. Personally, I really like the point about the paradox of doing something so well, and I think as Steve mentions, dentists are doing a great job of patient safety. But there's a paradox, is they do such a good job when occasionally there's an issue. It creates this, as I think Steve said, the sense of betrayal. As I would say, it's everybody else is doing it right, why can't you do it right? And it's an interesting point which I really hadn't thought about, the paradox of doing something well. Occasionally when you don't, it creates a PR problem, sometimes obviously a very serious problem for patients. But I want to thank our speakers, John and Steve. I want to thank the audience for dialing in. I ask you to look forward to our 4th teleseminar of the year. We're going to deliver our 4th as promised, probably in November or December. We're vacillating between a couple of very timely topics. So with that, I will say goodbye and sign off. Thanks again for joining us. As I've said, please tell other people about this presentation who didn't have a chance to dial in because they had a patient in the chair or some other commitment. We will be posting this program on the AADB website within 7 to 10 days. We'll have the podcast up and running, and many of your peers hopefully will listen as well. Thanks again, everybody. Signing off for today, and have a great day. Bye-bye.